Hi and welcome back to another video of Medic Notes. This video is on skin tumors. Skin cancer is categorized as non-melanoma skin cancer and melanoma. Non-melanoma skin cancer comprises basal cell carcinoma and squamous cell carcinoma. SCC has precursor non-invasive states of intra-epithelial carcinoma, Bowen's disease, and dysplasia, actinic keratosis. Melanoma is much rarer than non-melanoma skin cancer, but because of its metastatic risk, it causes most skin cancer deaths. The risk factors of skin cancer include UV radiation, genetic predisposition, such as in xeroderma pigmentosum, immunosuppression, organ transplant recipients, and chronic inflammation, such as chronic skin ulcers or lupus. First we look at basal cell carcinoma. This is a common, slow-growing malignant tumor that rarely metastasizes, but which can invade locally. Early BCC usually present as pale, translucent papules or nodules, with overlying superficial telangiectatic vessels. If untreated, they increase in size and ulcerate, forming a crater with a rolled pearled edge, and ectatic vessels. This is a picture showing a basal cell carcinoma. For management, the choice of treatment modality depends on local expertise and interest, and includes surgery, cryotherapy, radiotherapy, photodynamic therapy, or the topical immunomodulator imiquimod. All treatments used optimally can produce excellent cure rates. Next, for squamous cell carcinoma. SCC usually arises on sun-exposed areas with diverse clinical appearances, including keratotic nodules, exophytic erythematous nodules, infiltrating firm tumors and ulcers. Histological grade varies from well-differentiated to anaplastic, and lymph node metastasis may occur. For management of squamous cell carcinoma, complete surgical excision is the treatment of choice. Other options include curettage and cautery for small, low-risk lesions. And radiotherapy if surgery is not feasible. Wide excision has a cure rate of around 90 to 95%. In patients who are at high risk for further SCC, systemic retinoids may reduce the rate of occurrence, but rapid appearance of tumors occurs on drug cessation. Next, we look at actinic keratosis. Actinic keratoses are hyperkeratotic erythematous lesions arising on chronically sun-exposed sites. Histology shows dysplasia, although the diagnosis is usually clinical. They are treated easily and effectively with liquid nitrogen. If there is a large number of lesions, then the topical cytotoxic 5-fluorouracil may be required. Alternatively, topical imiquimod or photodynamic therapy may be used. Progression to SCC is rare, but should be suspected if there is ulceration, bleeding or pain. Next, for intra-epidermal carcinoma, Bowen's disease. Intra-epidermal carcinoma usually presents as a slow-growing, erythematous, scaly plaque on the lower legs of fair-skinned elderly women. Histology demonstrates intraepithelial carcinoma not penetrating the basement membrane. It may develop into SCC and should always be treated. A biopsy may be required to make the diagnosis, but non-surgical photodynamic or immunomodulatory therapies are commonly preferred on the legs, as they are associated with improved healing. Another skin neoplasm is keratoacanthoma. Although benign, this squamous tumor can be hard to distinguish from SCC, and therefore is included here. It presents as a rapidly growing, isolated nodule often more than 5 cm in diameter, with a central keratin plug. It is associated with chronic sun exposure and usually occurs on the face. Clinically and histologically, it resembles SCC. Most are treated by curettage or excision to rule out SCC, and to avoid the scar resulting from spontaneous resolution. For cutaneous lymphoma, it develops slowly over many years, from polymorphic patches and plaques, through to nodules, and then a systemic stage. As it can resemble other common conditions, such as persistent eczema and psoriasis, a high index of suspicion is required for diagnosis. Treatment is symptomatic and does not alter prognosis. In early disease, systemic or local corticosteroids may be indicated. Alternatively, psoralen plus UVA, or UVB may be used. In advanced disease, localized radiotherapy, electron beam radiation, or anti-lymphoma chemotherapy may be needed. Whereas for melanoma, melanoma is a malignant tumor of epidermal melanocytes and has metastatic potential. Incidence has increased over recent decades. Early detection and treatment are essential because of the lack of effective therapies for metastatic disease. The main risk factors for melanoma are prolonged UVR exposure, pale skin, large numbers of nevi, and positive family history. Melanoma can occur at any age and site, but is rare before puberty, and typically affects the leg in females and back in males. 5 subtypes occur. Superficial spreading malignant melanoma. Most common in Caucasians and characterized by a superficial radial growth pattern, which over time may progress to vertical spread. Nodular melanoma, a rapidly growing nodule, typically found on the trunk in men. It may bleed, ulcerate and metastasize. Lentigo maligna melanoma, occurs most often on exposed skin of the elderly as a pigmented macular area. It is preceded by a prolonged pre-invasive phase. Acral lentiginous melanoma, occurs on the palms and soles, particularly in dark-skinned people. And subungual melanoma, this is rare. It presents with a painless streak of pigmentation under a nail. For management of melanoma, the lesion should be excised with a wide margin. The Breslow thickness of tumor, which measures the maximal depth from granular cell layer to deepest tumor cells, is critical for management and prognosis. Clinical staging is essential to establish whether disease is localized or metastatic. Treatment may involve wider local excision, sentinel lymph node mapping, and biopsy. Prognosis for metastatic disease is poor and chemotherapy is palliative, but tumor-targeted genetic treatments are under development. That's all for this video. Thank you.